all comes down to, we don't trust you, right? You guys are idiots. We don't trust you. And that's the genesis of that is PBM.
Dr. Jerkins.
Dr. Palmer, how's it going?
Doing great. Doing great. Flying high off our guest today. I'm excited for it.
Wait, who's our guest?
Well, off the back of the Olympics, we thought that it'd be appropriate to bring one of the most legendary sports teams owners of, I would say, our era. You know, I would say for most of my life, I really haven't known owners to represent such a presence in the American culture space. Oh, yeah. And they do healthcare.
Yeah. I mean, they do healthcare.
They do healthcare.
So, you know, that's the thing is, so our guest today is the one and only Mark Cuban, who we were very excited to join us today.
Spoiler alert.
Spoiler alert.
It'll be in the show title.
That will be the show title. And as what we'll really dive into in this episode is what he's doing to innovate and disrupt in the healthcare space. As we love new ideas and we really love innovation within healthcare. And the basic question is, what would make things better for patients? And I think he's really thinking in a different way on that question.
I think that I am very excited to talk to Mark Cuban about so many things because of the breadth in which he has his professional life has lived. He comes from a traditional programming and tech background, obviously is very well known for being a sports mogul, now has really become kind of centrally positioned in the healthcare debates, both from a business standpoint, being a business owner himself, which we'll talk about with the Cost Plus. Of course, we're going to ask him about Cost Plus drugs and our own experiences with it, but then also what he's doing from a policy standpoint. Because we know healthcare, and we've talked about with some of our other guests before, healthcare is huge. And so it's really hard to fix it from any one direction. And so tackling it requires kind of this multidimensional approach. And I'm really excited to hear his thoughts on it, having been steeped in it for what sounds like the last six or 10 years or so.
Yeah. And I think people probably don't want to listen to us anymore. We should probably cut to the interview. What do you think, Ned?
No, I think a couple more minutes of us is what people always want.
Is that a good segue?
Yeah. We're like the amuse-bouche.
Let's get to the interview with Mark Cuban. Mark is an entrepreneur, TV star, MBA owner, and now a healthcare disruptor, bringing innovative ideas on how to make things better for patients. Mark Cuban, welcome to the podcast.
Thanks for having me, guys. Appreciate it.
Excellent. Well, let's jump in. I know a lot of people listening know you for lots of reasons over the years, but healthcare might be a new one. So tell us a little bit about how you got involved and interested in thinking about healthcare and innovation.
Well, around 2017, when the Trump administration came in, they were talking about getting rid of the ACA. And I had some friends that were involved with it. And they were like, yeah, we want to get rid of it, but we don't know what we want to do. And so just out of fear, I started digging into the healthcare industry and working with different projects and just trying to get up to speed. And then around 2019, I think maybe late 2018, I got a cold email from a Dr. Alex Oshmayansky. He didn't email me as much as you did, Michael, but he emailed me and he was like, we want to start a compounding pharmacy in Denver, where I am starting a compounding pharmacy in Denver, and we want to make generics that are on the FDA short supply list. And we think we can help kids that are facing issues. They can't get drugs for pediatric cancer. You guys know, all the drugs that are in shortage better than ibuprofen, et cetera, et cetera, et cetera. And I'm like, that's great. But is there something bigger? And that was right around the time the farmer bro, Martin Shkreli, was getting sentenced to jail. Daraprim. And so he was top of mind. Yeah, for Daraprim, right? And so I was like, okay, if this dude can jack up the price of Daraprim, to $7,500, this is not an efficient market. There's something going on here. So my first inclination was, okay, can we just screw with this guy and just, find the manufacturer of Daraprim and buy a whole year's worth? Turns out he already did it, right? So there was no capacity available. And so I was like, okay, this is a mess. Let's see what we can do starting with generics. But let's do it a little differently. We'll set up a website, but what we're going to do differently is we're going to be transparent, because the only reason you have this crazy pricing like that is because it's an inefficient market. And the reason it's an inefficient market is because there's zero transparency. And you guys know this better than I do. When you prescribe a medication, the first question you ask is, what pharmacy do you use?
That's right.
Where do you want me to send this?
How are you going to get it?
Yeah, how are you going to get it, right? And with no real discussion of the economics or the impact, et cetera, there's a presumption at some level that most people, and rightfully so, either have employer-based insurance or some other form of insurance. And, if you know somebody doesn't, then it becomes kind of a stress factor. And so what we said was we were going to create this website. We found the URL costplusdrugs.com was available. So that was perfect. But we were going to take a different approach. We were actually going to show our cost. We were going to have a standard consistent markup of 15% so that the price would always be the same for everybody. And then because we're mail order, there's a shipping fee and we needed a pharmacist to review. So we pay a pharmacist a fee. And that was it. And as a result, when you netted all that out, our price was not only readily available for anybody to see, but far lower in most cases on generics. And so that just got us started. And so we launched with about 115, give or take, generic meds on January 19th of 2022. So only 2.5 years ago. And just me and my big mouth going out there and talking. And literally, the response was great, but we didn't have enough drugs. And our challenge then was, how do we get these generic manufacturers to trust us? And that was one of the reasons I put my name on it, because, I'd never put my name on a company before, because I wanted all these manufacturers to know that we were serious and that I was fully backing it. And so as I began, using my platform and talking more, just the word spread that gave comfort, and we started creating volumes that gave comfort to the manufacturers, who then sold us more generic drugs. Then we, I think we're up to 70 branded medications, and then we just kept on growing. So now we're, in the range of 2,500 SKUs, different medications, and having served millions of prescriptions, and it's just blown up. And the most impactful thing that we did wasn't just be transparent with our pricing, but it was actually producing a price list. If you think about it, any normal business, if you ask for a price list, okay, no problem, right? Here's the price list. That didn't exist prior to us. And where it's been impactful is researchers have been able to take our price list and compare them to other prices they've been able to get anecdotally. And so you can go and get prices from CMS to see what Medicare and Medicaid are paying, but no one ever had a commercial price list to compare it to. We come along and boom, right? And so as a result, early on, there were all kinds of studies from Vanderbilt, from Harvard, saying that if CMS had purchased for Medicare these 9 drugs, these heart drugs, they would save $3.6 billion.
Wow.
These, 9 urology drugs, 900 million, et cetera, et cetera, et cetera. And so all that just expanded word of mouth. And one of the reasons I'm here with you guys today is we don't spend a penny on advertising or marketing. Not a penny, because we have to keep our prices low. And our attitude was, and you guys, in our crosstalk before this said, yeah, you've recommended us because, some of the most extreme savings we've offered are, like on imatinib. When we first got in, if you walked into a CVS, you're paying $2,000 for imatinib. If you're an employer and you self-insure and you didn't know any better, which 99.9% of employers don't, you're paying $2,000 plus for imatinib. And, then there's MS drugs, there's, a variety of other drugs. And so, I had a friend who needed droxidopa. I have no idea then what it was. I still don't. But he lost his insurance, and it was like he was going to have to pay $10,000 every 3 months for this generic medication, and our price was $64 a month. And so, the point being that we had such insane savings on so many critical drugs that patients, once they found out, they tell each other. They go on the Facebook groups, and obviously they tell their doctors. And those doctors typically treat other patients with the same maladies and need to prescribe the same medications. And so, boom, that took off. And then, you have us boomers, right, who wanted great prices on generic, Cialis and generic Viagra. And when I told my buddies that you could buy, 90 Tadalafil for less than you pay for a bag of M&Ms, your wife will thank me. So, that word of mouth took off really well too. And so now there's a lot of happy couples with a big bowl of what used to be M&Ms next to their bed. And so And literally, we're probably approaching 10% of the cash generic Cialis and Tadalafil market. It's
That's
insane.
that's incredible. We'll maybe pause the visuals there and not take that a bit any deeper. But there's a million channels to explore this with. But kind of right at the end, you talked about what you're doing to grow customers, both from the pharmacy side, from the manufacturing side, and then also the customer side. What have been some of the biggest challenges with scale that you've seen?
So there's only been, initially it was a big challenge just keeping up with the growth, right? How do you build, partner with pharmacies that can handle the scale? And, we've had to slow things down actually, and continue to at a certain, for certain medications, just because it's hard just to get a pharmacy who can scale with us. But the bigger challenge has been dealing with brand medications where the minute they start talking to us, one of the big three PBMs tells them, look, if you do business with them and offer this to them and they sell it like they have been, we're going to, either remove you from formularies or de-emphasize you. So we'll put a competitor up front.
We'll fight you.
Yeah, we'll fight you one way or the other. They can't say that out loud, obviously, but that's what happens. And so that literally has been our greatest challenge. And we're finally working around that now. We were originally adamant that we would only work on a net cost basis, meaning if the net after rebate for a brand drug was $100, we would only pay $100 in a market of 15, as opposed to working through a rebate style approach. But we just recently changed that, so you're going to see us aggressively adding brands here over the next year.
That's incredible. I want to pause for a second and talk PBMs, pharmacy benefits managers. They are well known to players in the space like yourself. I would say they're very poorly known to our community of doctors, though, as call it that unpleasant, invisible hand of the market, right? Really driving costs, and with the rebate program.
For sure.
I was wondering if you could just pause real quick and give us the Mark Cuban rundown on PBMs and how they interface with your business and frankly, who the big three are in the space, if we're comfortable naming them. They're listening, so yeah.
Yeah, I won't name them, but let's talk just about the supply chain and how it all works from the time you issue a prescription, right? So you say, I want to prescribe X medication. The first step is whether it's our pharmacy that we partner with or the local pharmacy or a big chain like Walgreens, right? They have to have that medication in stock. And so in order to get that in stock to fill the prescription that you write, they buy from typically one of three wholesalers. And those big wholesalers typically work from a price called NADAC or a WAC price, actually, where they say, okay, the price we're going to sell to the pharmacy is WAC minus 7%. So basically it's a discount off of retail of only 7%. Okay. So now let's just say it's Eliquis. Eliquis is $600 retail, right? And so they get 77% off of that. But let's make the numbers easy. Let's pretend they get 10%. So now they paid $540 and you prescribed Eliquis, right? And so then the question becomes, does the patient have insurance? Yes or no? If it's no, then they have to walk in there and pay the $600 and the pharmacy makes $60. If it's yes, they do have insurance, then what happens is they go to the pharmacy, they hand the pharmacy their insurance card, and they already have the prescription, and then here's where the pharmacy benefit managers come into play. And so what happens then is the pharmacy runs the insurance card, sees that the person who provides the insurance, whether it's from the ACA marketplace or from an employer, says, okay, somebody's got to process that claim. I've run this card. That is what the PBMs do. And what they do then also is they also negotiate with either the generics manufacturer or the brand manufacturer. More often than not, it's the brand manufacturer that comes into play here, obviously with Eliquis. And they say to the brand manufacturer, the retail price of Eliquis is $600. I put you on my formulary, so this big company emphasizes Eliquis over some other blood thinner, right? And so they said you're going to get a lot more prescriptions because we put you at the front of the formulary. So in exchange for that, we want, and I'm pulling numbers out of thin air here, we want an 80% discount, right? So I'm going to pay you 20% of of $600. So I'm paying you $120. And it gets a little bit more complicated from that, but then they go to the employer and they say, hey, we've got this deal with you. We've got this deal with the manufacturer of Eliquis. We got a great deal from the manufacturer. They gave us 50% off.
Yeah. Yeah.
Right? And so you're getting 50% off and it's only
You're welcome.
$300. And oh,
Yeah.
by the way, yeah, you're welcome, right? And that difference between what they actually pay the manufacturer and what they get paid back by the employer or the insured, the source of insurance, is called spread pricing, right? And the games that PBMs play with spread pricing and rebates are the root of all the hate and animosity that goes to PBMs. But wait, there's more, right? So there's that spread pricing. But let's just say they did a deal. I like before we started Cost Plus Drugs, I had a deal with an insurer that connected me with a PBM, right? And they did all these spread pricing things. But we wanted to get some claims data so we can analyze our claims. We don't own our own claims data. The PBM would not provide that to us because think of the chain of custody here, right? You write the script, goes to the pharmacy, goes to the PBM, and I don't, for HIPAA reasons, I don't know what each individual employee is prescribed, et cetera, et cetera. They're not telling me. I don't want to know, right? But I do want to know on a general sense the health and wellness of my company, who truly needs GLP-1s, what wellness programs can I put in, right? So not only can I not get my claims data, I'm not by contract allowed to even talk to Lilly or Novo about GLP-1 programs they may or may not have, right? And so the PBMs interdict themselves into the process. And there's 3 of them that control about 80+% of the market and 6 of them that control 92% of the market. And then the other 8% are through what we call pass-through PBMs that pass through the entire rebate. So you get the full 80% off and we'll give you all your claims data. We'll work with you with the PBMs and they give you control of the formulary. So for instance, there are now biosimilars for Humira, right? And there are multiple biosimilars. The big PBMs want you to use a biosimilar that they control, that they price a little bit different, a little bit lower than the retail of Humira, which is what, $8,800 a month, something ridiculous, but has huge rebates. So then they can go to employers and say, oh, look, we got you 50% off. But there's also biosimilars like Usimry that Cost Plus Drugs carry, that's $594 a month. And so the pass-through PBMs will work with us and put Usimry on the formulary, but the big PBMs will not. They'll just keep on ripping the employers off. And so you guys face the challenge now as doctors of saying, well, I can save you money, right? Let me prescribe Usimry through Cost Plus, and then the insurance company says, no, it's not on the formulary, right? And the reason they do that is because the PBM that either owns them or they own, one of the big 3, is keeping that spread on the cost. And they even play worse games. So where they deal with big manufacturers or big employers, right? Let's just say you're dealing with an employer with 50,000 or more employees or lives covered, right? With families and everything, right? And so those big companies, they'll have their their HR people or their benefits people say, you're giving us 100% of the rebate. We're not going, we know the games you played. So what does the PBM do? They literally go overseas. In 2 out of 3 cases, they go overseas in Japan or Ireland, I think it is, and they create something called a GPO, a rebate aggregator, a GPO. And that rebate aggregator then negotiates with the manufacturer to get the 80% off, maybe a little bit more. And then they say the pass through is only, a 50% rebate. And so now legally and truthfully, quote unquote, the PBM can tell the big employer with all those lives covered, we're giving you our entire, rebate. We're not holding anything back. This is what we get. They don't say that the company that the GPO is owned completely by them, right? They don't disclose any of that. They don't. And wait, it gets even worse, right? Not only can you not get your own data from the manufacturer's perspective, right? That it's not like the manufacturers don't realize this is a ripoff, but the manufacturers are terrified, like I said earlier, that they're going to be diminished or removed from the formulary. And they're so terrified of that those PBMs can also charge fees to the manufacturers to get data. The manufacturers who you think needs the data the most because you want to have the best clinical evidence that you possibly can have to make decisions on what you prescribe, do not get full data from the PBMs on all of their claims for their meds. But wait, it gets worse.
It's like the worst Billy Mays pitch I've ever heard, Mark.
Just when you think it can't get any worse, right? It gets worse, right? So you may have noticed that there's a lot of smaller pharmacies that are going out of business around the country. And here's why. Remember, going back to what I said, that the pharmacy buys that brand Eliquis or any brand medication from a wholesaler, right? At, in our example, 10% off. Well, when you prescribe something and send it to a local when you prescribe a brand and send it to a local pharmacy, again, we'll just keep on using Eliquis. They're no better or worse than the others. Then what happens is that PBM has to reimburse that pharmacy, right? Because the PBM collects money from the employer. That money goes to the PBM, and the patient that walked in maybe paid a copay, maybe had a zero deductible or copay. So the pharmacist gave them a drug they had just paid $540 to this, and they want to get paid, right? They need to get reimbursed. Now, those beautiful PBMs that we love and adore, they don't reimburse them the full $540. They'll reimburse them $520, $530. And if it's a really expensive drug like a GLP-1, they might short reimburse them over $100. And then they'll audit them after the fact with these things called DIR fees and rip them off even more. So when people talk about the hate for PBMs, I mean, I just don't understand where it comes from, but at least now you understand why.
I think that's a whole hour-long podcast just talking about PBMs.
No, that's it in a nutshell right there, right? That is it. Now you guys, all you doctors now understand why people hate PBMs, why you hate PBMs, right?
For what they're doing to our patients.
Right. And then, the same system works on the healthcare side too, right? I mean, the games they play because they're all integrated with the same BUCAs, the same insurance companies, right? And so, the spread pricing you're seeing on in-network versus out-of-network, right? And the games they play with algorithms to determine that spread pricing, and so we're creating a whole nother company called Cost Plus Wellness, where we're going to do direct contracts and publish those contracts. So you guys will be able to see them.
That's amazing. I mean, the transparency is such a big deal. And I'll be honest, like clinically, when I'm seeing, 20, 30 patients in a day, I'm fielding calls and I'm just trying to deliver care as efficiently as possible. And it's really difficult to step back and file the prior authorization and figure out which pharmacy has a medicine and pricing. So you're just trying your best to practice within a system that's entirely inefficient.
Completely inefficient. And it's the lack of transparency that does that. So when you look at it from the healthcare side, okay, on one hand, you prescribe, right? And that's a hassle in and of itself, particularly when it's not on formulary what you want, or they deny it, or they tell you to do step up testing, right? Yeah. Mm-hmm. Step up. Yeah, which is ridiculous, right? So, I mean, it all comes down to, we don't trust you, right? You guys are idiots. We don't trust you. And the genesis of that is PBMs. And so where the opportunity arises for you to talk to insurers, let's just say you do a lot of work, not insurers, with self-insured companies. Let's just say you do a lot of work with a particular company, right? They send a lot of patients to you. If you get the opportunity, tell them to use a pass-through PBM, because the difference is the pass-through PBMs are going to let the employers and you together set the formulary. They're not going to make you go through a step-up process. They're not going to, and the crazy part is, the one thing about all this is there's fewer pre-auths for medications now, because they want you to prescribe as much as possible because they make so much money on the rebates.
It's crazy. Well, can you talk about the wellness piece? You just talked about the Cost Plus Wellness. Can you tell us a little bit more about that?
So before I jump to wellness, let's just say that all your electronic prescribing software, we're under Mark Cuban Cost Plus Drugs. So we're in the system, and you can prescribe this. You guys have done it, so you can give them details on exactly how to do it, please, because that's the biggest question we get.
Searchable right from the pharmacy search box. Yep.
Right. Yeah. So you just put a Mark Cuban Cost Plus Drugs, and you can search, and we have our list of 25, and it's really easy. You can even tell the patient while they're in the waiting room, hey, go to costplusdrugs.com, look, and let's check to see if the pricing and if you can afford it, and do they carry it. So it's really simplified.
I literally do that in the room, and it's not talk about inefficient. I mean, but the problem is, I've worked in mostly places where there's access issues, there's affordability issues, and rural areas and urban areas. So I will go on my phone and pull up Cost Plus Drugs and go over the medicine options literally to go through that with them. And there are many times where, in particular, where I really used it even a couple of years ago was colchicine, where, a medicine that's been around forever and ever and ever, all of a sudden someone gets an FDA approval for, I don't remember the backstory, but then all of a sudden it's extremely expensive for a medicine that lots of people need for various reasons. And it really provided an affordable option to get that medicine from your company. So
appreciate it.
Yeah.
And also know this, when our price goes down, we pass it through. So if you follow us on Twitter at Mark Cuban Cost Plus Drugs, or just Cost Plus Drugs, you will see almost every weekday since last September, we've announced a price decrease.
Wow.
So when we get because our volumes go up, our prices go down, and we pass those through. So even if there was something you prescribed through us before, it probably is cheaper now than it was before.
That's incredible. Colchicine's been around for 2,500 years, and the idea that they got a patent on it a couple of years ago just broke a part of me inside. So I was thrilled to hear that it's out there and able to be used.
That was a fantastic first half of our interview and conversation with the one and only Mark Cuban. Ned, we talked about a lot. I think I learned a lot on pharmacy and PBMs, more than I probably have ever known. I probably have to rewatch it and sketch out a diagram just so I can remember and understand it all. It's the complex flow of money.
I completely agree with you. We're probably going to need to spin up some show notes that include a glossary defining some acronyms. We may have to put some legwork into this because he was leaping out ahead. I think we wanted to explain like I'm 5 years old, and I think we're at a graduate school level. So we're going to bring the materials into the show notes and try to make sure everybody really captured what you were saying. Clearly, Mark's very passionate in the space and wants to educate other doctors on it. And it was a value having him on the show speaking our community.
Absolutely. And stay tuned for the next episode where we talk more healthcare policy, dip our toe into politics, even a little sports, if that is of interest to you. But we are very excited to share that part of the conversation on the next episode.
I appreciate that we're filming this 2 days after the Olympic closing concert with Snoop Dogg and Dr. Dre singing the next episode in LA. So I'm really looking forward to the connection here. And so please stay tuned for the next episode. Thanks for joining us this episode. You can catch the podcast For Doctors by Doctors on Apple, Spotify, YouTube, and all the major podcasting platforms. If you enjoyed this episode or learned anything here today, please take a moment to give us a rating and subscribe so that you don't miss a single episode release. As always, thank you for listening. And the next time you see a doctor, maybe you should prescribe this podcast. We'll see you next time.